It's my pleasure to be here. It's my pleasure to be here, and I have to apologize because I never attended these meetings. So I hope the format and the content is as you expected. I brought two cases. One is, as we in Germany would say, purely neurosurgical, and the other one is something like a mixture of neurosurgery and orthopedic thing. You will see, but I start with the purely neurosurgical one. Can you see my screen?
Not now. It's okay. Getting better. Yeah.
How about this?
Okay.
Okay. I hope you can see it now. As I said, the first one is this neurosurgical case. It's a rare case, but obviously sometimes it happens. Some of you who may be experienced in intradural surgery and so on may very well know this, not from own experience, but from reading. The reason why I show it is because I saw it the first time, and the clinical appearance is absolutely not typical. So let me start with the patient's history of this case one. It's a 69-year-old female with absolutely no history except for abdominal surgery 6 years ago. So there were nothing was pointing out in getting some spine problem. The acute thing was she had a re-ileus and had abdominal surgery, which was absolutely uneventful. It was in a supine position, and she had a peridural catheter. So we got a telephone call after surgery when the patient was awake, and the colleagues in another hospital, which we are working with as consultants, and they say, okay, we have a patient that cannot move her left leg anymore, and she has sensory deficits in both legs. And we made a CT, and there was no pathological finding, and overall surgery was uneventful. So we let the patient come, and she had a high grade iliopsoas palsy. Sensory was left femoral hyposthesia and a circumferential hyposthesia of the left lower leg. No spasticity, but most of all, she was not able to walk on her own again.
So Thomas, can I just ask you something?
Yes,
how
of course.
many hours, how many days delay were between onset of the neurologic deficits post-op and the call to your department?
It was 2 days. At first she wasn't examined appropriately, and then the colleagues tried to wait. Maybe something improves. They didn't know what happened, and they waited for improvement. And after 2 days, there was no improvement. So the patient was transferred to our department, and the first thing we did was electrophysiology. In the EMG, there was no spontaneous activity. This is more or less self-evident because it was only 2 days ago. The SCPs were normal, and the MEPs showed a, marginally prolonged latency to the left leg. So frequent things are frequent, and rarities are rare. So we thought about plexus or lumbar spine, and you probably can see there's nothing. It's absolutely nothing. So next thing, thoracic spine. And there is a finding that is absolutely typical for somebody who knows it. And to be honest, I didn't know what this was. I saw there was something that wasn't normal, but my colleague, whose name was on the first slide, he said, well, that's a clear thing. I've read about this, but nobody has in our department has seen this on his own. So there is this. Can you see the pointer? So there is this irregularity in the T1 posterior to the spinal cord, and in the T2, see the same thing as a bright signal and a small, very, very small syrinx. Okay, here it's highlighted.
So there's something going on in the checked box already. And may I ask you, before I ask our neuroradiologist what she thinks it is, were your neuroradiologist aware of what this is? Did you get immediate hint from the radiology department?
Well, they said seems to be an arachnoid cyst, but obviously it wasn't present in the mind of our neuroradiologists. So they said it's an arachnoid cyst, which comes pretty close to the pathology that it really was.
Maybe ask Wendy. Can you see the screen? Can you see the slides as well? Can you perhaps give your input what you see?
Yeah. So it was already described very nicely there. Except I would describe it a little bit differently. It's the cord itself that has the abnormality. It's not behind the cord. That would be an arachnoid cyst if you were to describe a rounded structure behind the cord at T1. Here we're seeing a deformity of the cord itself. And it's that cord deformity that's causing the syrinx right above it. And that's what we call the scalpel sign. And that's an arachnoid web. There's something interesting though about these. I found out, we always think from our textbooks and our boards, everything's very cut and dry, but it's not. And a lot of times these things can be a combination of multiple things. It's never, it's not always just one thing or another. But in this case, this looks like a pretty classic case of a web.
And how often do you see this, Wendy? Is this once a week, once a month?
So it's amazing because, our imaging is getting so good that I am seeing it much more commonly now than I used to. I think it's much more common than we used to think it was or is. So I wouldn't be surprised if I saw it maybe once every couple months. I mean, it used to be, you'd think there was, one a year or something, but now it's not uncommon. We see a ton of spines though. So maybe that's another thing. Ton of spines and good imaging probably makes a difference.
Mm-hmm. And how often do you see it combined with a pathology, with a clinical finding? Is that a thing that you mostly see as an incidental finding?
So that's very interesting too, because whenever we see it, nobody's ever expecting it. Number one, so somebody has symptoms and we're looking and we find it. We say, oh, that might be it. Probably is it if there's nothing else. But a lot of times the person is in for something else, and I see it. I would say at least a third of the time where I don't think the person's symptoms are related to it. It's just there. So yeah, so you never know.
What would you say is the most common thing? Is it thoracic myelopathy? Or is it something like we have? Because we had in this patient, we thought, or we had discussions whether the clinical symptoms had to do with this finding, or if it was an incidental finding,
or if it's an incidental. I think
so that was our main problem.
I think in your case, because you have, there's a variable degree of what it's doing to the cord for different patients. You already have a syrinx, which would make me think it's a little more likely to be causing the symptoms than cases that might not have a syrinx. But I don't, but it's hard to tell. But I think, pain is probably the most common. That's what they come in. That's just what I see.
Well, I probably have to add, the patient had no pain. She had absolutely no pain. She had this more or less peripheral femoral palsy, and she had diffuse sensory deficits in both legs, left more than right. So this is a thing that made us think it might not even be related to this finding, and it was an incidental finding. But we had nothing else, absolutely nothing else. She is a healthy lady of 69 years that has one disease so far, that was an abdominal one, and but it didn't. She didn't.
May
recover.
I ask you something, Thomas?
Yeah.
Do you think it's coincidence with the abdominal surgery, or has anybody from the faculty, from the hosts, experience of maybe intraoperative hypotension, anything that happens with the blood flow or anything like this causing deterioration of this arachnoidal web? Michael, I know you've done several of them. Have you had this history before in your experience, or is this just coincidence?
I've treated about 4 or 5 of these in my 3 years in practice, so since I started at Upstate a few years ago, and not one of them has ever presented like this. They've all had thoracic myelopathy, and one of them actually had a thoracic radiculopathy, but I've never seen someone present in quite this fashion with such pronounced neurological deficits before.
Okay, Thomas, what happened then? What did you do?
Well, this is the axial. Before I say what we do, this is the axial MRI that showed that there is something going on actually behind the spinal cord. But what did we do? So this is the lesion impression of the spinal cord, a small syrinx, and extramedullary. So scalpel sign, absolutely right. So we started reading, of course, and those are images of a myelography, which we did not do. We had a cis imaging and good T2 imaging. So we think we didn't need this, which in a review article of about 40 cases, it seems to be the standard of diagnostics. So we didn't do this. But the problem is she did not recover. And the first thing we ruled out is that it had to do with abdominal surgery or with a peridural catheter. She had a peridural catheter, and this might have. This is what we thought. What we suspect is that there's hematoma or something like that. But she didn't have anything of that. The sensory deficit minimally improved, and the weakness was unchanged after 14 days. 14 days, why? Because we said we do not know whether it has to do with this. We offer you surgery, but we don't know if it has to do and if it improves. And it took her a while to decide that she wanted surgery. Okay, we did a laminectomy, T4 and T5, and resection of the arachnoid web. Under intraoperative monitoring, which was fine at the beginning and it was fine at the end. And then we did laminoplastic reconstruction, just in case there is a revision surgery. And we have intraoperative ultrasound and images. And I would like to start with the ultrasound. Those are images that I put into this presentation just in case my video didn't start, but I guess I can get it. I can start it, and it shows you more in 5 seconds that that could be about the pathology that could be explained by many words. This is what the arachnoid web does. This is CSF pulsation. I'm not sure if anybody has ever seen this.
Thomas,
like
can you go to the screen sharing and go to the window with the ultrasound with the video, because we only see the window of your presentation. Yeah.
How about this?
Brilliant.
Okay, and this shows that there is that the CSF pulsation gets trapped in some kind of a bladder in this web, and it bounces back, and obviously it causes an impression of the spinal cord from behind. Let me show
Oh,
this
Thomas,
again.
may I ask you, is intraoperative ultrasound standard routine in your surgery, or is this something you order
Yes,
in special cases?
Yeah, good question. We use it whenever we can because it's non-invasive. It's always there. It can always be repeated. It's no danger. So we use it. We use it for this kind of pathology, for localization, for verification that we have the right level. And we even use it when we do, for example, a laminectomy of the cervical spine in degenerative stenosis, just to verify that that the decompression is fine. So we use it whenever we can.
Oh, so Michael, may I ask you? You're a neurosurgeon. You're very experienced. Is ultrasound something you use as well?
Yeah, absolutely. I use it for any intradural case that I have like this. I don't usually use it after a routine laminectomy, but any type of intradural tumor, that's usually my secondary confirmatory modality that I use after using a fluoroscopic guidance. So for a case like this, I would absolutely use ultrasound for it before and after we excise the cyst.
Okay.
So some intraoperative video sequences. Sorry for this being so red. Photoshop didn't work for a multiple gigabyte video. So this is the surface of this web, and what you can see here is some kind of a calcification, which we didn't expect. And the pathologist said, well, no problem, it's just calcification in some kind of a arachnoid-like structure. Okay, let me advance a little bit. Of course,
so
the red thing is irrigation. Pardon me?
Thomas, you didn't find any kind of hemorrhage, any kind of injury due to the peridural
no hemorrhage,
procedure?
No injury. It's just a complex structure of arachnoid-like. Well, the name arachnoid web is actually it tells a lot, or it tells the whole story. And it was fenestrated at this point of the of surgery. And now let me get the next video, just real quick. Okay, this shows that it's not only an arachnoid cyst. It's some complex web-like structure that traps the CSF. And well, it's still red. It didn't start bleeding. It didn't stop bleeding. But in the end, the whole structure was resected, and electrophysiology was unchanged. Here you can see the web-like structure.
Thomas, I'm curious, what were the motor evoked potentials like in the SSCPs before you started the surgery? Were they asymmetric or were they completely normal?
They were a little asymmetric, but just like the MEPs before that we did when the patient was transferred to our hospital, it was not a very clear asymmetry. It was asymmetric with a prolonged latency on the left side, the tibial MEPs.
This is a gorgeous video. I'm going to put a little plug for Virtual Spine here. We have a YouTube channel with all of our prior videos from this. And way back at the very beginning when we started, whenever that was, the beginning of COVID, whenever that was, one of our first ones, if anybody wants to see the radiology perspective on how we differentiate web from arachnoid cyst from cord herniation, I gave a presentation on that. So it's in our archives. And so if you want to see the different imaging characteristics and the figure you actually used, the drawing, the nice picture you had, that figure, that actually was drawn by my colleague, Matt Skalski, who I worked with on a presentation on this a few years ago. And now it's It's made the
So
rounds.
it was
It's out
the
there everywhere. It's
ideal,
perfect drawing.
the ideal citation.
Yeah, exactly, exactly. I wish I had drawn it, but.
So Wendy, it was in April 2021. It was like 2 weeks after the lockdown, your
Wow.
presentation.
Yeah.
It's really, it's a rendezvous. It's a déjà vu.
April 2020. Is that what you said?
Yeah,
April
2020, sorry.
Okay,
2020.
yeah, I was gonna say. Seems like a
So
long
Thomas, and how did the patient do?
Well, let me go back to the presentation. Well,
While you're doing that, how long does something like this take? How long did this surgery take?
surgery took about 1.5 hours. Well, no, it took about 2 hours, including the plastic reconstruction of the lamina. I can't get the presentation. Can you see it now?
We can see it,
Oh,
Thomas.
no.
It
I
works
also have
fine.
to say, those are the most gorgeous spinal ultrasound pictures I've ever seen. That's just amazing. I've only done that twice when the neurosurgeon asked me to come up to help out, but that was just gorgeous. That's beautiful images.
Thomas, do you do an expansile duroplasty after this case, or do you just close up the dura primarily?
No extension plastic. We just closed it, and you can see the. Okay. You can see the ugly post-op MRI. We did a primary suture and put Tahosil over it, and this is what it looks like after insertion of the lamina reinsertion. At dismission, there was no change of neurological deficit at first. And at 5 months, and obviously I cannot show you the images anymore. She had a persisting hyposthesia of the right lower extremity, improvement on the left lower extremity, and she had no motor deficit anymore.
So.
And there was supposed to be a video that proves that the patient is walking absolutely normally, but this seems to be not working. Sorry.
So Thomas, you told us that the patient was not able to walk before surgery.
Yeah,
and
because of
how many days was the delay until you took her into the OR?
14 days. That was, I mentioned
days.
before that, from the first notice of this of the high grade palsy until surgery, there was 14 days thereafter. There was no change of neurology.
So it's atypical clinical findings. The history is atypical. If there was another call with the same situation, would you take her earlier into the OR, or would you just wait again?
We probably offer the patient surgery in a different way. I probably would say that, well, early surgery is probably the link to early recovery. But I don't know. This is atypical. And for the next case, I hope that the neurological deficits in the history are more typical, to be sure to offer the patient or to convince the patient that surgery is the appropriate thing to do.
So this was a great case. Can't wait to see the next one.
Okay, and this was the MRI 5 months thereafter. A little irregularity, maybe a rest of the syrinx, I don't know, but the little hematoma has completely gone away. Was that the last slide of this case? Yes, it was.
So brilliant. Does everybody do post-op MRI imaging several times, or does anybody say, okay, I go, when the patient improves, I don't do imaging?
I personally like to get one because, we do these cases so infrequently, Alex, that I think we'd love to see radiographically what it looks like. So I always will get a post-op MRI after a case like this.
Okay. Okay. Thank you, Thomas. The next one looks, is the one with this neurosurgery and some kind of orthopedic, or is this just?
Correct.
Okay, can't wait.
So it started with the telephone call. It obviously always starts with telephone calls. It was not an external hospital. It was an anxious young woman that said, "Doctor, my mom has a meningioma, and she's had surgery 3 times, and she can't walk anymore. And they say she can't be operated anymore, and she needs radiotherapy, but she can't walk. And radiotherapy is going to start next week. And her breasts touch her hips." And you have been recommended by a friend of ours. And I said, "Please send me the MRI and I'll have a look." What I didn't know at that time is that it was not only one hospital that said they can't be operated anymore. She went through a large area and university hospitals of large areas, but she only that was probably the mistake, and she only consulted very, very specialized and conservative neurosurgical departments. Well, that was the image. She sent me one CD, and that was the image that I saw. This is the meningioma, axial view, but there was but later on, then I called her, and then she piece by piece told me the history. In 1999, she's had surgery for a meningioma, T5, via a laminectomy, T5 and T6. In 2020, she had surgery for meningioma T8, and they did a laminectomy T7 and T8. That was the image that's what they took out. And she did not improve. She got worse. She had a near complete paralysis and insufficient recovery, so she couldn't walk. And that's why they did it was 2021, reopening laminectomy T4, dural extension plastic, which didn't improve her state. Okay, and after that, she got an MRI again. That's what we saw. And if you review the course of this meningioma, it started growing. And this is what they found was not to be operated. It was inoperable, and had to require radiotherapy.
Thomas, I'm curious,
what do you think?
Sorry, I apologize for interrupting. Did they only do laminectomies, or did they take pedicles and facets down to try to get anterior? It looks like it's pretty ventral.
It is pretty ventral, but this is what I meant with conservative neurosurgical departments doing surgery only from posterior. And this is what resulted in a, well, in the end, if you add it, it's a 5-level laminectomy. And they obviously, we have the report, the surgery report, and they said there was a very vulnerable spinal cord, and there was tumor up anterior to it, and we cannot touch this the spinal cord anymore, so it's inoperable. What would you have done? Radiotherapy or?
No, I think, Thomas, in that situation, I had a case like this about 1.5 years ago where a surgeon had done a laminectomy. They lost their motor evoked potentials when they cut the dentate ligament and attempted to rotate the spinal cord. So they backed out, and they actually left the dura open. And I took her back 2 years later after radiation therapy, and it was a mess in there. But I think you have to take the pedicles and the facets down. You have to almost do a costal transversectomy to get a better line of sight and maximize your anterior corridor. So I disagree with them that this is inoperable. It's definitely operable, but it's probably going to require a much more extensive bony resection.
Wendy, what would you say?
I get to be the surgeon now, huh? Yeah. So it seems like we do a lot of radiosurgery. Is there a reason not to do that in this case? Especially if it's so aggressive that it's growing back
Yes,
I mean,
it
combo
grew
both,
back, but we thought it's a damaged spinal cord, and with an incomplete and insufficient recovery. If you take a close look at this, it is swollen down there where the tumor was at T8. So the spinal cord has an edema, and we thought, well, don't do. I told the young lady, I'm not sure that radiotherapy would be the best thing. And well, take a look at this. Can you see both of those images? Because I can't.
Because
the spinal cord is the one thing. The other one is remember her breasts touch her hips. This is what this is the spinal column in a lying position, in a supine position in the T-scout, and this is in the upright position. So there is a mobile kyphosis, which well, you can't leave it like this. That is what we thought. So we have a combined neurosurgical and orthopedic problem. We have a kyphosis which has been progressive in the last couple of months, and we have this insufficient recovery.
And Thomas, I think the other important point too is that because she's having progressive kyphosis, she's kyphing over that tumor, right? So it's almost like doing a laminectomy for a thoracic disc herniation. So she has residual tumor, and on top of that, she has a 5-level laminectomy, correct? So she's actually kyphosing over that tumor.
So this is complex, and we exactly did what you said. We did a transversectomy. She was informed that it may be a costal transversectomy, but we tried it, of course, guided by ultrasound. Then it was enough to take the transverse process out in 2 levels, T4 and T5, and it was unfortunately, I don't have any intraoperative videos, but it was easy to take the tumor out. There was no adhesion to the spinal cord. It was just like it was only just like a camel, like the back of a camel, like 2 bumps, and they were absolutely. It was easy to do this operation and to get it out. And that's what we did then. We figured it was enough or sufficient to fix her in this to do an osteosynthesis in the lying position, and not do more, not force her in a normal position, but just make it like just a look that she doesn't go in an increasing kyphosis when she's standing up.
Yeah, Thomas, I think that's fantastic. I would have done the same exact thing that you would have. I think the hard part for the original surgeon is understanding when they need to instrument up front and take the pedicles down and take the facets down so that they can get as anterior as they need to, because there's a lot of cases where you can do a dorsal laminectomy, dorsal durotomy, and get away with rotating the spinal cord and take the tumor out. I think a lot depends on how friable the tumor is, how calcified it is, and kind of things along those lines. So
I can tell you it was soft. It was soft. It could almost be the interior of the tumor could be removed by suction, by simple suction. And then you had the capsule, and the capsule was removed just like easy meningioma, basically. So it was just a matter of the approach, which seemed obviously it was the right approach that we took, because post-operative course, well, okay, it was not uneventful. She lost a lot of CSF, and she had a little hemorrhage, intracerebral hemorrhage after surgery, which was clinically not apparent. And she had a large CSF fistula. We did a puncture twice of 140 milliliters of CSF. And finally, we did revision surgery. Sutured the dura again. The length of stay was, I can't see my own, it was 58 days. And, but it was worth it, obviously. Get a fairly good recovery. As far as you can see it by the art, considering the artifacts, the tumor is out, and there are screws in here that don't appear in this sagittal image, and she's mobile again in one of those four-wheel walkers. So it was successful, and okay. Maybe you asked the question again, how long this surgery took, and that was about 8 hours.
So Thomas, I think that's a fantastic result. I'm curious what your threshold is to do a costotransversectomy or pediculectomy with facetectomies up front for one of these, multi-segmental ventral meningiomas.
They are not so common, but I'm not afraid of these extensive approaches, and they are, and actually I'm a friend of this of the anterior transthoracic approaches, but not for disc herniation, for example, but not for tumors. This may be my neurosurgical heart or neurosurgical education. We try to come from as posterior as possible, but the costotransversectomy or transversectomy, I think it's an approach with a good overview to the anterior parts, and especially of the border between the tumor capsule and the anterior margin of the spinal cord. So for me, this is an approach I'm fairly used to, and probably that is not the case with those in those departments she's been before, and she's been suggested radiosurgery, because in the end, I can just tell it again, say it again, it was easy to remove this tumor.
Thomas, I think one of the downsides to doing instrumentation for intradural tumors, obviously, is that these people expectedly have a pretty normal life expectancy, and we want to be following these scans serially over time. And once we put titanium and cobalt chrome hardware in, it's very difficult to see it. So as user unfriendly as carbon fiber instrumentation is, I'll throw it a quick plug in that I've actually used carbon fiber screws for cases like this before, so that you can follow it over time. So I think that's not a bad indication for it.
As a matter of fact, we discussed this with me expecting this virtual global spine conference. We discussed it yesterday in the department, and one of my colleagues said, probably they'll ask you why you used titanium. We used titanium because we had it in the stock, and we didn't actually. I did at the time of surgery, I didn't really think about post-operative imaging. It was just, it's a mistake, as you can see in this image.
Mistake, but it's
not a mistake, but it's suboptimal.
That's probably something.
I absolutely agree with you.
It's a relatively new thing to have carbon fiber though, right? So it's probably not always on the top of your mind to think to use it, right? Still, because it hasn't been around that long, right? And still expensive, I'm sure, for you.
Right. We all think about you.
Well, it's not about expensive. This is a thing that I would do differently if this patient is going would come tomorrow. I would order the carbon fibers. Well, it was not an emergency, so she could have waited another couple of days until the instruments were there. We don't have them in our stock.
I have a different question, which I want to make sure I ask it in the right way. But we often have global spine conferences about complications. Everybody wants to know, and everybody here is so nice, sharing their complications. I don't know if we have a good one here. He was one of the first to do that for us. But for your brain hemorrhage, that looks like the location and kind of the shape of it looks like that might have been venous. That's something we learn about. That's a complication. It's rare of spinal surgery, but that can happen in the posterior fossa from spine surgery or during associated with. How often do you all see that? I've only seen it maybe twice ever. I haven't been around that long, but
every once in a while, after very a strong CSF loss.
Okay. And so is that? So
that's by the way, we also see this when we do like frontotemporal approaches in patients with atrophic brains, that they have hemorrhage at different parts of the brain, like in the cerebellum. It may be just a matter of CSF loss.
Wendy, it's a great question. I've had it once in my career. About a year and a half ago, I was doing a posterior cervical thoracic revision deformity in a morbidly obese patient, and there was a lot of scar tissue. We got into the dura, had a very small CSF leak, had it repaired, and after surgery, the patient had a tonic-clonic seizure, had a venous infarct, and then a few days later ended up developing cerebellar edema, had cerebellar hemorrhage, developed hydrocephalus, needed a ventriculostomy. He ended up doing fine, but this was after about 2 or 3 months. But interestingly, we really didn't lose that much CSF during the case. I've had many other cases, especially some of these, many hour intradural cases where we've lost significantly more CSF, and something like that doesn't happen. So I think there's really no rhyme or reason. I don't quite understand the pathophysiology behind that.
Thank you. That's interesting. What about you, Alex? Any comments?
Yeah, same. I think we have to mention two facts. First, complications. We have every surgeon has got complications, but what we don't have is a classification system of complications. So we just mentioned the amount of complications like dural tears and like fistulas, CSF fistulas, but nobody says, oh, I have this grade of complication, because just the dural tear maybe has no consequence at all, and the patient gets up 6 hours later and walks home and is really happy. And then we have got the dural tear, the same complication with a catastrophic outcome. And I always wait for this classification system so that we can say I've had a grade 3 or grade 5 complication, surgical complication. In abdominal surgery, there's a Clavian classification, pretty well known, worldwide used, and then you can put your complications into a classification system, and you can say this or this or this. So we only do a narrative. We are mentioning our complications just by numbers or narrative, and we just warn our colleagues and we warn our residents, please avoid this. And if this happens, go to this step. But I think we have a lot to learn, and I'm looking forward for the future for this complication classification systems. May I have a look to the timetable? We have got some 10 minutes to go. Thomas, I have one case from a thoracic myelopathy as well. I don't know whether I managed to share my screen. I don't know whether I'm able to.
Well, at first I'll stop my screen sharing. Well, thanks
yes,
for the attention.
I need some help here. No,
Alex, if you're unable to, I actually have an interesting case that I can show, but go
yes,
ahead.
of course. I have some troubles with my firewall here in the hospital. I would be glad if you can show one case, Michael. But I read Matt wants to mention something. Or is the signal lost? Or Michael, can you share your screen?
Are you guys able to see this?
Wonderful. Thank you.
Yeah, so I'd actually like everyone's take on this case. This is it's an interesting case I did about 5 months or so ago. This was a 12-year-old guy who presented to us with progressive low back pain, and he had some leg cramping and right lower extremity numbness and weakness. And
hey, Michael, can you hear me?
Yes.
Sorry, man. Can I make one quick comment? I'm getting on a plane, and I just wanted to
absolutely
say real quick, and we'll move on. That last case. The other thing we don't have, speaking of complications, everyone knows I'm not afraid to show my complications. The other thing that I think should be said is that, thank you for doing the right surgery. I mean, I think one of the problems is that we see it a lot in spine where there are lots of surgeons that don't do the right surgery, and one of the reasons is probably because the complications that come along with it. So, you look at that case, you can probably tell the patient ahead of time, hey, there's the risk of all sorts of things, and it's still probably the right thing to do. And I feel like that's something that comes up a lot. I don't know the answer to making I don't know, maybe making people understand that or somehow making that more clear. But I feel like there's a lot of times when the complication profile is acceptable, even though it's severe complications, even though there are things that could happen and will happen. So I just think it's people don't want patients to have a 50-day stay. People don't want to take that risk. So I don't know what the answer is to that, but I do think it's a problem in spine surgery. Sometimes the right surgery takes a decent amount of risk that for the patient is actually probably worth it.
Awesome. Thanks for the comment, Matt. Alex, do you want me to go ahead and show this case quickly? It should take a couple of minutes.
Oh, yes, please. You're wonderful.
Sure. So this was a 12-year-old kid that I took care of a few months ago, and he presented with back pain, leg cramping, was still very ambulatory and still quite functional. And he recently had a dirt bike accident, and it was felt that his back pain was maybe secondary to that. But when you took a deep dive into his history, he was actually having these symptoms prior to his minor little bike accident. So Wendy, what are your thoughts about this MRI scan here at first glance?
Yeah, so you've got this tumor just distal to the conus, kind of cauda equina area. It's intradural, extramedullary, kind of pushing those nerve roots forward. Looks like it's pretty homogeneously enhancing on your axial. That sagittal, I'm not sure, but it's a little bit T2 hypointense. Usually a lot of tumors are T2 hyperintense, although your CSF is pretty bright, and I'm not quite sure what kind of image that is. So a couple things live in that area. I don't know if you want me to give, I won't give a diff yet. That's how I would analyze it in terms of appearance and location. I'm not quite sure what your bottom image is showing on that axial. I'm not sure if that's
they're just two different cuts from the same tumor. Basically, one is at the top of the tumor, one is at the bottom of the tumor. That's all.
Is the bottom one also a post contrast?
I believe the bottom one is a T2 and the top one is a T1.
So it's just showing there's no CSF on the bottom, maybe.
Right.
Okay. So it's filling the canal. It's causing symptoms.
Filling the canal, and you could go over the differential if you'd like. I mean, I think this one's pretty obvious. Is it?
It's not a trick like Alexander would play on us?
This is not a trick, no.
Sorry, I have to mention something. I want to ask you, Wendy. If you say 2T hypo,
T2 hypo,
does it make a difference between intradural, intradural or extradural? Is this two entities you separate, or do you think, okay, we have to put them together?
So because a T2 hypo, A T2 hypointense tumor could be in either place. All that is saying is it's a highly cellular tumor, something like, a sarcoma, lymphoma, maybe a met from, I don't know, medulloblastoma, something like that, round blue cell tumors. That was the significance of that. You had mentioned, or somebody had mentioned, like nerve sheath tumor. Those are T2 hyperintense. So that was my point in that comment about the signal characteristics on T2 of the tumor itself. But they could live anywhere. So I don't know if it answered the question, is it all intra or extradural? Is that?
Yes, this was all completely intradural. We scanned his entire neuroaxis up to his brain, and he had no other spots anywhere. It's a little hard to make out. He did have some little, you could kind of see it down here, little contrast enhancement down behind S1, S2. I'm not really sure if that's artifactual or what that is, but we saw that as well. So I'm curious, Thomas, what would you do for a case like this? And there's a particular reason I'm bringing it up. Obviously, intradural resection, take the tumor out, but what would you do as far as, would you do a laminectomy? Would you do a laminoplasty? Would you do a lami fusion? This is a 12-year-old boy who still obviously, is going through his growth spurt. He's not done growing yet. So what are your thoughts about that for a long segment?
I would do the laminoplasty.
Would you do that even though this is right at the thoracolumbar junction?
It's a 12-year-old kid.
Yes.
Yes, I would do it.
Yeah. Mike Selby, what are your thoughts about this? Stripping away everything from low thoracic to upper lumbar, taking interspinous ligaments. What are your thoughts about, longevity of maintaining, upright sagittal balance in a case like this?
Yeah, I mean, I've dealt with multiple cases where, decompression or plasty has been trialed for this that have not done well. And I think a shorter segment fusion now you guys, Michael and Thomas, how much can you give me? That distally L2, I reckon, if we just took the L2 lamina down and didn't violate anything distal to that, can you get away with stopping there? Maybe I'd need to see some erect films. But, I feel as though thoracolumbar junction is plagued by these issues, less so than thoracic spine. I would lean towards instrumenting this pretty strongly, actually.
Right. So I'll show you what I did for the sake of time. I ended up doing a 3-level laminectomy because that's what was needed to access the rostral and caudal components of this. And this is after we did our laminectomy, opened up the dura. Here's our cauda equina here. I unfortunately don't have a video. I just have a few pictures, and you can see here's our tumor. We found the phylum above. We found the phylum below. Here's our anterior dura here. We were able to stimulate this and eventually ligate that, section it, and then we were able to roll out the tumor on block. And I thought this was a very nice way of going about doing this. And I did what Thomas had said. I did a laminoplasty. I was a little bit hesitant about doing a multi-segmental thoracolumbar fusion on a 12-year-old like this. So this was his post-op MRI scan. We got everything out, nice gross total resection. And this was just a little bit of video just showing that we got everything out. And here's our laminoplasty here. I actually used cranial plates. And what I did was I took some non-absorbable suture, I stitched it through the spinous process above, and then I reconstructed everything. I think Thomas probably as you would have done, and this is the specimen after we took it out. So here's the first post-op MRI, upright x-rays immediately after surgery. Here's our laminoplasty plates here, and he's got beautiful sagittal balance, nice coronal balance too. He had maybe a very touch of like 10 or 12 degrees of scoliosis even before surgery. Now this is him. I just saw him last week. This is him 4 months post-surgery. So Wendy, what are your thoughts about the change between immediately after surgery and 4 months now? Is this of any significance? I'm curious all of your thoughts.
So that's something usually people don't care if I think it's significant, but it looks like you've got more of a lordosis there, quite a bit of lordosis. More than you had before? That's all I can see on my screen.
Yeah, well, correct. And that's basically, even our radiologist didn't even pick up on this. So the first thing I saw, actually the patient saw it. He said, my spine is more curved than it was before surgery. I said, you're exactly right. he's hyperlordosing his lumbar spine, and that's because he's now starting to kyphose a bit at the TL junction. You could see that this vertebrae is touching the anterior part of the vertebrae just caudal to that. You can see that, the disc space is not completely parallel as it was immediately after surgery. So this is the current state of affairs with him. He's back to riding bicycles. He's swimming over the summer. He's fantastic. He's doing great neurologically. He's doing amazing. And he has no complaints. He has no back pain. His parents don't notice any postural issues with him. But obviously I picked up on this and I'm a little bit concerned about it. And part of myself is kicking me that I didn't do an instrumentation up front. I'm just not sure how many people would have done that for a case like this. So what are your guys' thoughts? What should I do with him? Should I just continue watching this? Should I submit him to a multi-level fusion or brace him, send him to PT? What's everyone's thoughts at this point? Completely asymptomatic. Posture looks beautiful when you see him in person.
Michael, I'd sorry, Michael. I reckon I'd look at bracing him at this point. I mean, I don't think it's disastrous. It's just he's young and he's got a lot of growth left. And so if you can get him in a brace in a better posture for 20 out of 24 hours a day, still let him be active and exercise, you might be able to keep it at this, and that'll be ideal. I think if it keeps going, though, you're committed to an instrumentation. So,
right.
I think bracing for kyphosis, generally in boys, I've found very effective. In this exact situation, I can't tell you I've got huge numbers, but I would probably brace him at this point with the aim of, keeping his shape. But I think he'll tolerate that shape currently. It's just if it gets worse, I think you're going to run into trouble. The only comment I'll make is that on that radiograph, he's got his arms out, right? And so that gives you a little bit sometimes of a false impression. And I think, the radiographers, the techs do their best to show us the whole spine, but sometimes that more natural balance with the arms touching the clavicles that you get in the EOS scanner gives you a little bit more of a read on exactly how much kyphosis there is there. So, but I think a brace would be pretty reasonable at this point.
Okay, right. So Mike, on the other view you showed, he had a little bit of, I don't know if he had coronal imbalance or not, but that curvature doesn't matter on this one. Does that going to get worse, or is that okay?
No, he actually had a little bit of coronal imbalance. I don't want to even call it coronal. He's not really imbalanced. He was a touch of a coronal curvature even before surgery and his upright x-rays. So I'm not too concerned by that. But, just like he's a little bit more hyperkyphotic, he does have a little bit more, maybe 4 or 5 degrees more, if that, of the lower lumbar spine here afterwards. So it's a good pickup.
Yeah, and I wasn't even going to say it was because of your surgery. I just wondered if he had that process occurring and developing anyway, regardless of everything else. So
yeah, Alex, I think you had a comment you wanted to make as well.
No, I think Australia was right. What Mike Salby told, that I think it's, what is your experience with these young patients? So I always wonder, if less is more, maybe it's good. The young people are so, you can't expect always that the natural history that there's always deterioration. We know from Scoli that some degree of scoliosis after bracing, wow, we don't have to do the surgery. In kyphosis, I'm not so sure. My experience is that kyphosis is deteriorating quite more often, but I would brace as well. I would not put an asymptomatic 12-year-old boy into a brace. There's something going on in his life, and I would wait and make controls like you, I think, are planning. What is the next X-ray? 3 months or 6 months?
I have another one in another 12 weeks, and I'm doing exactly what you guys talked about talking about giving him a brace.
Yes. So thank you very much.
Alexander, can I make a quick comment? It's an ad, actually. It's an advertisement for you, for our host. So when we were talking about the signal characteristics of the tumors, the T2 hypointensity, I just want, for those of you who didn't see it on Twitter, I want to make sure you knew that wasn't regarding your case, Mike, because that was a little bit different. It was a nice case posted on Twitter from our guest. I think, was that your case, Alexander, or was that her case? Was that your case?
This was my case here.
That was your, okay, so it
This
was a nice case of a sacral tumor. So everybody go on Twitter and take a look at that case if you want more of all this. If you missed your sacral tumors today, you can take a look at the discussion around that case. And it talks about both the surgery and the imaging findings. Sorry, I did plug that real quick.
Yeah, thank you, Benny. This was a great session. It was so interactive between the disciplines, some ortho, a lot of neurosurgery and neuroradiology input. It was great. Thank you, Thomas, that you showed us your cases. It was fantastic cases. And good night to Bavaria. And who's next week? Next week, we have got a great topic. It's about artificial intelligence in spine care. I think Matt, are you there?
Yep. Can you hear me?
Yes, I can hear you.
Yep. So next week will be Joe Schwab from MGH Harvard, who's kind of led the charge into AI, machine learning, and as it applies to surgery. And he will be with us, kind of sharing his knowledge. And if you have never heard Joe speak, or if you don't know Joe, he's just outstanding. So it should be a great session.
So a lot to learn about artificial intelligence. Thank you very much. Thank you to the audience, to the participants for your interaction in the chat box. I really appreciate your comments. And I say good night and bonne nuit à Paris to all our guests from Paris. Have a nice time. Goodbye.
Bye.